Hey, it's Paul again. We're going to talk about laboratory and diagnostic testing today. So let's get started. To start with, we'll talk about some basic laboratory tests. But first, I think you need to at least be exposed to the terms sensitivity and specificity. Now, sensitivity essentially is the ability of a test to include all the people who have a disease, even though you'll get some false negatives that you exclude. All right, so a good screening test then is one that includes everybody who has the disease, but maybe you'll exclude some false negatives. Specificity then, on the other hand, is the ability of a test to exclude those people who don't have the disease. So the best test then is one that's both sensitive and specific, but there are very few tests like that. Most tests are either sensitive or specific, or, they're pretty good at both. So if you're mathematical about this, you can actually think about it this way, because this is how we actually arrive at these numbers, sensitivity and specificity. We do the math and we do a study where we look at the test and we say, of the people who take the test who have a true positive, then we divide that by true positive plus the false negative, and that number is the sensitivity. Similarly, the specificity is decided here. But at the end of the day, these sensitivity and specificity, they're really just tests of the test. And they ask the question, given a patient who has disease, what is the likelihood that the test will be positive? Well, think about that. That question is kind of silly, right? These tests are not useful when we're talking about individual patients. What really matters for individual patients is the positive predictive value and the negative predictive value. That is, given a positive test, what is the likelihood that the patient has disease? And given a negative test, what is the likelihood that the patient does not have the disease? And so you see the math is a little different, and those are the important questions. So really, we talk about sensitivity and specificity of the test, but at the end of the day, what we really care about is the positive and negative predictive values. All right, that's way more than you ever want to know in an undergraduate course, but this is really the crux of how we use of testing theory, I should say. So, from a more clinical standpoint, with you and I at the bedside, what we're really interested in is how do we do this, right? How do we practice as nurses? So, there are many different blood type or blood collection tubes that are out there. You probably are most familiar with the red top or the tiger top. This is called a marble top, that I'm accustomed to calling it a tiger top, where it just has these black marks on a red tube. Now, this typically, either one of these is used for general serum chemistries because they allow the blood to clot in the tube, and because we don't need the red blood cells, or the thrombocytes or any of that. All we need is the serum. So we don't mind if the blood clots here, and then we can get rid of it. Light blue tubes then are used for, light blue blood tubes are used for coagulation studies, and green are used for specific studies of chemistry. I don't recall the ones specifically that are used for green or that we need a green or gray tube for, but the hospital policy will dictate that. And then lastly is the lavender top tube, and those are for CBCs. You may work in an intensive care unit that has a little iStat machine. These are very convenient because they allow you to do a lot of testing right at the point of care, which is particularly nice in the middle of the night when you're working nights and you need to schlep down to the lab. You can just pull this up at the bedside and get it done there. So it's similar to a blood glucose monitor. You can just grab a little bit of blood, enter it into the machine. The machine does all the testing, and you get a result. Similarly, these conveniently sized ABG testing machines will also allow you to add on some things like carboxyhemoglobin and potassium, calcium, things like that. And those are convenient machines to have at the bedside or in a stat lab of some sort. Now, it's important that you know when you run blood tests on an ABG machine. So if you're interested in the potassium, for instance, remember that these ABG machines are actually using whole blood instead of what you get with one of those red top tubes, which is just serum, right? So the concentrations of things like potassium, calcium, etc., those are different in whole blood. So the reference range is going to be slightly different. Make sure you pay attention to that. So those are all things that I'm sure are just review for you, but I want to make sure that you understand about blood cultures. So remember that blood cultures are really important for treating infections most accurately and appropriately. If we use empiric therapy to treat microbial infections, then we often get it right, but maybe not always. We may be guessing at the most appropriate antibiotic based on, our, again, best guess. What we really like is to have blood cultures that guide the therapy and are specific to the particular organism that we isolated. So the way we do this, the standard practice is with each fever, and a fever, by the way, is not, just a little temperature of 99 point whatever. A fever is 100.4 degrees or 38 degrees Celsius. So with each fever spike, at least once every 24 hours, we get 2 sets of blood cultures. And in each set, we get 2 bottles, right? We get an aerobic and anaerobic bottle. And we do those 2 bottles. We wait 20 minutes, go to a separate site, and get another 2 bottles every time the temperature reaches 100.4 in a 24-hour period. Okay, so that's an important thing because, again, this helps us to pick the right antibiotic and make sure that we're treating the patient with the best agent. Next, we're going to talk about the blood count. So up here in the corner, I wrote the way that we write down the complete blood count by hand, and this might be a useful thing for you to use clinically. You can write the WBCs here, hemoglobin and hematocrit here, and the platelets. And notice those are the only 4 things that we really care about on a CBC, right? So in the intensive care unit, we care about the WBCs. We don't care so much about these things, but we do, but what we're really following usually is the white count. And then we follow the hemoglobin and the hematocrit and the platelet count. Some of these other things like the RBCs and the MPV and the RDW and things like that, we're not as concerned with those because they have something to do with determining what type of anemia it is. What we're determined to figure out is if they have anemia, right? What's the hemoglobin? If you're a medicine person, it's hemoglobin that we go by. If you're a surgical person or peds, they often go by the hematocrit. Know that the hemoglobin is about 1/3 the hematocrit. So if the hemoglobin's 8, which is what I'm accustomed to thinking about, what's the hemoglobin? If the hemoglobin's 8, then the hematocrit is 24-ish. I think that's right. 8 times 3, 24. Sound right. And then here we have the MCV, which is the mean corpuscular volume. And that volume then is what we use to determine the size of the red cells. And then we use the MCHC to figure out what color they are. Are they normochromic or hypochromic or hyperchromic? Those are the things that we use to figure out how much hemoglobin is actually concentrated in that sample. All right, so that's the CBC. Next, then, we have the basic metabolic panel. This used to be called a Chem 7 years ago. Now it's called a BMP, or basic metabolic panel. And that has the usual things. Again, I showed you the little shorthand way of writing it. Sodium, potassium, chloride, bicarb, BUN, creatinine, glucose. Just a couple of points. I want to point out to you that the BUN is not a great indicator of renal function by itself. Instead, the creatinine is really the best spot check of renal function. All right. The BUN is actually a function of the liver, because ammonia, which is the byproduct of protein metabolism, goes to the liver and is combined with CO2. And when that ammonia is combined with CO2, that creates BUN, right? So if you think about people who have liver failure, you remember that the ammonia levels get really high. Well, the reason is that the liver's broken, and when the ammonia comes back to the liver, it can't be combined with CO2 to create the BUN. So patients with liver failure have essentially normal BUN, but they get super high ammonia levels, and that's the problem. So, speaking of liver problems, when you have liver failure, you typically get a comprehensive metabolic panel, or a CMP, to help guide your therapy. And this includes all the usual stuff from the Chem 7, right? The bicarb, the the bicarb, the chloride, the potassium, sodium, etc. It also gives you liver function tests, and the ALT, the AST are two of the liver function tests, or the transaminases, that are best to evaluate liver health. But notice that in severe liver failure, so think of it this way: you come in, you get an acute attack of hepatitis. So you have acute hepatitis, viral, bacterial, whatever. You get this hepatitis, and your AST and ALT go really high, 5 times the reference range or whatever. So 250 for your ALT, for instance. Over time, over years and years, as your liver fails, there will be fewer cells that can actually produce the ALT and AST. Those are enzymes that are released when the cells break down. And so over time, the number of cells that can die anymore are reduced. And as a result of that, the AST and the ALT levels are very low in late liver failure. But what we follow in somebody who has super late liver failure is the proteins that are produced in the liver. So the albumin is produced by the liver, and if your albumin is really low, and your AST and ALT are normal, and the PT is very high, because there are no clotting factors being made by the liver, then that's a good indicator that you're in severe liver failure. You might want to back that up and listen to it a time or two again, but that's what I'm trying to get across to you, that we can figure out what stage of liver failure somebody is in, or at least get an idea from the history combined with these laboratory tests to tell us the health of the liver. So the common laboratory tests that we get in the ICU are the coags, right? So we get the PT/INR. We use that for patients on warfarin, and we also use it, as I just explained, in gauging liver failure. And then the PTT is for heparin. So remember that Plavix and aspirin and Plavix and aspirin and Brilinta and the other antiplatelet agents don't get a blood test. There isn't a blood test. Well, there is, but we're not going to talk about that. We don't monitor a blood test for antiplatelet drugs. Chemistries, we talked about already, sort of the serum potassium, calcium, magnesium. Those are the ones that we're most concerned with ordinarily. Sodium is also one that we're concerned with, and we want to make sure that patients have the right level of sodium so that they're in a homeostatic place. Unless we decide that we want to affect the sodium and give hypertonic solutions of saline. Maybe that would be helpful for edema in the brain, for instance, and it is. Next, we're going to talk about lipids very briefly. Remember that there's this thing called the phospholipid bilayer. Remember that from your old anatomy and physiology days? A phospholipid bilayer is part of every cell membrane that's in our bodies. And how do you think you get that? Well, you use cholesterol to create those cells. And remember that when you have surgery or you've been in trauma or, you're just severely ill and in the hospital, your body has to remake these cells. And when it does that, it uses up cholesterol. So critically ill patients, particularly after surgery or trauma, are in the ICU and they have low cholesterol levels. So we're not going to bother talking about cholesterol much in this course, just for that reason. We don't need to treat it because it's already low. B-natriuretic peptide, BNP, not to be confused with BM as in metabolic P, is produced by the atria in response to atrial distension. So as volume overload happens, the atria stretch, and as that stretching happens, BNP is released. And so this is an indicator of heart failure and fluid volume overload. High sensitivity C-reactive protein, or CRP, is a marker of vascular inflammation, and it can be elevated in many different things, but that is a useful tool in determining if somebody has ongoing coronary artery disease. The D-dimer is a test that you'll see used frequently to exclude people who have pulmonary embolism, or DVT, I should say. So the cool thing about D-dimer is that it's very specific. See that word there? Remember sensitivity and specificity? D-dimer is very specific for clot. So when we see it elevated, we know there's a clot somewhere in the body. But it's not, it doesn't tell us exactly where the clot is. It just says that there's clot. So if you cut your finger, then there's going to be clot, right? Or if you have a DVT, there'll be clot. And so that D-dimer is only useful for telling us that you do have clot. Now, we can also use that along with fibrin split products to determine if you have DIC, or disseminated intravascular coagulation, which is a complication of sepsis and trauma, pregnancy, etc. And then lastly, there's these enzymes and cardiac markers. And I want to just go through this pretty quickly. Notice that when somebody comes in with a heart attack or chest pain, we always get a set of cardiac enzymes, and then we do serial enzymes over a 24-hour period. And this is the reason that we do that. So notice that, and remember that when cells die, enzymes are released from those cells into the bloodstream, and we can measure those. The very first one, the lightest one that's released, is myoglobin. Now, myoglobin is not specific to any particular kind of muscle. So myoglobin is released whether you get punched in the arm and cells die, or whether you're having a heart attack. So it's not specific to any particular kind of tissue. But notice it's the lightest, and it gets released within 6 hours of the injury. Very close to that, though, is this troponin, right? So troponin I and troponin T peak very early at about 8 hours or so. So the troponin is just about as good as the serum myoglobin. Now, we used to use serum myoglobin all the time before we had the troponins, because if we saw somebody in the emergency room who had chest pain, 4 or 5 hours beforehand, they came to the emergency room, we do a set of cardiac enzymes. If their myoglobin was normal, then we knew that they didn't have a heart problem, right? We knew that their chest pain was not from a blockage in the arteries, because if it was, then that myoglobin level would be elevated right away. Now, we don't really use the myoglobin anymore because the troponins really peak very, very soon thereafter. And so we can get a very good idea about whether somebody's really having a heart problem based on that troponin. Now, sometimes people's troponins are elevated and we don't expect them to be, and so we would check that against a CKMB. So creatine kinase is another enzyme that's in all muscle, whether it's cardiac or skeletal muscle. CK will come out of any kind of muscle. The specific isoenzyme CKMB is cardiac specific, and so it should also be elevated, but notice it peaks closer to 18 hours than what the troponin does, which is closer to 8 or 10 hours. So we do measure these things over a 24-hour period, and we see what the peaks are, and we see, if they come in with coronary disease and chest pain from that, then we should see elevated CKMB and CK and troponin and myoglobin if we look for that all at once. The other things that we can look for are LDH, but we really don't look at LDH much anymore. And in fact, I've kind of forgotten how to evaluate LDH for chest pain, so let's just pretend I didn't mention it. So another test that we use all the time is electrocardiography. And so all about EKGs. The first thing to know about EKGs is that when we look at a 12-lead EKG, what we're really interested in at the outset, of course, we read the rate and the rhythm first, right? And then we want to know the axis, because the axis tells us the mean electrical vector. Remember vector from Despicable Me? A vector is a mathematical term that describes the mean direction of current and the magnitude, right? It's a mathematical term indicating direction and magnitude. Oh yeah, remember that? So when we do this, we have to first think about what the EKG reflection means. So in A here, we see that when an impulse is traveling toward the positive lead, we get a positive deflection on the EKG. When the impulse is traveling away from a positive lead, we get a negative deflection. And then if the impulse is traveling sort of perpendicular, we get this biphasic or isoelectric, where it's a little bit below, a little bit above, and not very noticeable because it's so close to the baseline. Those isoelectric things are very useful because they're the opposite of the mean electrical vector. And so we use that when we're trying to figure out what's the direction of the current. So if the direction goes down toward the left hip, if that's the direction of the electrocardiographic vector, then we would expect that's probably coming from the top part of the heart going down to the bottom, just like the normal EKG would. But what if the vector is going up to the right shoulder? Well, that's the opposite. So I'll bet that what's causing that is probably a ventricular rhythm, right? So if the mean electrical vector goes to the right shoulder instead of the left hip, then that's probably originating in the ventricles. So these are the things that that a 12 lead helps us to determine, because it changes all the electrical activity. So let's look at the limb leads here, and remember that there are 6 limb leads, and notice that they all have different shapes. So in lead 2, when I said, it goes to the left hip, that's what lead 2 is. It goes from the right shoulder to the left hip, and this is the direction of flow, which is kind of this way, right? The direction of the electrical current. And that means that this is going to be positive because it's going toward this lead. But notice in AVL, this is kind of isoelectric, right? So the impulse, when it travels from here to here along this lead, or along this vector, is perpendicular to this lead that's monitoring in AVL, and that's why you get this biphasic shape. So these are the things that we use and we put together when we try to figure out what the axis is. But notice that we also have this other thing. So with the precordial leads, now we're looking at what happens in the in the transverse plane. And so now that we try and determine what the vector is with respect to the chest. And so when we put this all together, we put the V leads on the chest like this, and this helps us to look at what's going on in the transverse plane, as shown here by this green thing. And then the 6 limb leads we use to figure out what's going on in the frontal plane, and we put it all together and we get this. We get a 12 lead EKG with lead 1, 2, 3, AVR, AVL, AVF. These are the 6 limb leads. And then we have the 6 chest leads, V1, V2, V3, V4, V5, V6. Now, it's even cooler than that because we can group these together and we can see different parts of the heart and the vessel that feeds them. So if we look here in lead 1 and AVL, this is the high lateral leads, and V5 and V6 are the low lateral leads that are supplied by or the heart muscle of which is supplied by the circumflex coronary artery. And then the inferior leads are 2, 3, and AVF, and those are supplied by the RCA. And then we have the anterior and the septal leads. Septal leads are V1 and V2, and the anterior leads are V1, V2, V3, and V4. And those are the anterior leads. That's all supplied by the LAD. All right. So I realize that this is very, very superficial, and it doesn't give you a great idea about these things, but hopefully it makes you look forward to learning about them more in the future. And by the way, any critical care nurse worth their weight in gold, or is worth their weight in gold, if they can interpret these cardiograms just as well as the cardiologists can. And it is totally possible. It's easy to learn this stuff when you use it every day. And I encourage you to make this an interest. It's fascinating, and it's a really fun thing to do. And you'll take better care of your patients, and you'll also have the respect of all the physicians with whom you work if you can interpret EKGs. Same with ABGs. I think that's another good way to get to establish yourself clinically. So next we'll talk about echocardiography. Of course, we're doing all the cardiac stuff first, right? Because I know you dig that. This is a little baby who's getting an echocardiogram in the intensive care unit, and I just want to explain to you what echocardiography is. So it's an ultrasound study of the heart, right? Now there are 2 different ways that we can do it. We can either do it transthoracic, which is what that baby was getting. You put the transducer on the patient's chest, and you shine the sound waves down, and you see the reflection back, and that appears on your screen. But we can also do Transesophageal Echo, where it goes down into the throat, and that helps us to look behind the heart, which is even a better way of doing it. Well, I should say it's a different way of doing it. We get crystal clear pictures, and it's very cool. So the components are 2D echocardiogram, which are just videos of the heart in motion. And then we can also do Doppler, where we get we get to use the Doppler principle to look at blood flow. So there's 3 different kinds of Doppler. There's color Doppler, continuous wave Doppler, which looks at blood flow all across a line that we draw. And then pulse wave Doppler, where we look at just like here at the tips of the mitral valve leaflet, for instance. We would do pulsed wave Doppler there, and that helps us to determine what the flow characteristics are across that mitral valve. So the first thing to learn is that there are these different views. So there's these apical views. This is an apical 4-chamber for obvious reasons, right? This is the left ventricle. This is the left atrium, right atrium, right ventricle. And so this is the apical 4-chamber view. This is an apical 2-chamber view where the transducer is just turned 90 degrees to make it an apical view. And this you can think of as sort of being the transducer is sort of below the nipple on the left chest. And then the peristernal window is the 4th intercostal space or so, 4th or 5th intercostal space along the left sternal border. And here you get the peristernal long axis. And again, you turn the transducer 90 degrees and you get the peristernal short axis where it just cuts through the heart like that. You get to see the left ventricle and the right ventricles up here. So this is the transthoracic echo. Usually the echo tech sits behind the patient, reaches over and does the echo here. This is actually the peristernal long axis that's showing up here, and this is where the transducer gets placed for that 4th intercostal space-ish, left sternal border. And by the way, some of these patients have really bad acoustic windows. So smokers in particular, people with COPD, bad lungs, tend to have very difficult echo pictures. And remember that sound waves don't travel through air very well. They travel through water, they travel through tissue, but they don't travel very well through air. So that's why those things are hard for those patients. The other cool thing about transthoracic echo is that it's good for looking at anterior structures. So what's an anterior structure? Well, like the right ventricle, the aortic valve is very easy to see from the front of the heart or from the chest wall, but it's really hard to get good images of what's back here in the back, like the left atrial appendage, for instance. So to do that, we like this transesophageal echo, which goes down the patient's throat. Patient's asleep for this, of course, and we can put that sound wave right behind the heart and shine that picture on there, and we get terrific pictures, such as these. So these are the transesophageal echo, or TEE views, and these are the transthoracic views that correlate with these. So this is the apical 4-chamber that we talked about, peristernal long and short axis, and then this other vena cava thing, but we didn't even talk about that. And here you can see the transesophageal echo windows over here. It's a really cool procedure. You get pristine pictures that are really pretty. So there's Doppler echocardiography, where we can actually use the sound wave to get, we can use the Doppler effect. So remember, the Doppler effect is where you're standing at a train station and a train comes to you, and as it gets closer, the pitch gets higher of the train whistle, and as it goes away, the pitch goes lower, right? So that's the Doppler effect. And we use that same science to figure out what the flow of blood velocities are. Next thing is stress testing. Stress testing is used for 3 things, really. We determine functional status. How much can somebody exercise? How healthy are they? How well do they go on the treadmill? And then we can also risk stratify people. So based on the fact that they exercised for, 10 minutes on a Bruce protocol, for instance, I'm pretty sure that that patient is at very low risk of dying from a heart attack in the next year, for instance. And then we also use it for medication monitoring, like antiarrhythmics and beta blockers and things like that. So the two types of stress tests that we use are exercise and pharmacologic. Now, the exercise treadmill test can give us both functional status and risk stratification, but a pharmacologic doesn't tell us anything about their functional status, right? It doesn't tell us how long they exercise because they're not exercising. They're getting medicine that simulates exercise, like Persantine or Lexiscan or something like that. In addition to the stress modality, we also get an imaging modality. So we get an EKG for everybody, even the Persantine. And then we also can do an imaging study with either echo or nuclear. And when we use nuclear imaging, we get really good information, including assessment of the heart muscle function, which is very cool. So let's talk briefly about what happens during exercise. So when you exercise, your systolic blood pressure goes up, but because your temperature, your body temperature is increasing, you're vasodilating. And as a result of that, your diastolic blood pressure goes down. So that's the normal thing that happens with exercise. Notice that if you have multivessel coronary disease, the blood pressure actually drops during exercise, and that's a bad sign. That means that you have left main coronary artery disease or multiple multivessel coronary disease. So blood pressure going down with exercise, really bad prognostic indicator. Normally the systolic blood pressure goes up, diastolic blood pressure goes down a little bit, and along with that, the cardiac output increases and the coronary perfusion increases as well. But if you have one blockage, then maybe the coronary perfusion goes down, right? If it's a 60% or more blockage, then that coronary perfusion is going to go down. And that's all what we figure out with the stress test. So how do we know if somebody has a positive stress test? Well, we put them on the treadmill, we hook them up to the 12-lead EKG like this, and we tell them to walk. We monitor their blood pressure and we monitor their EKG. And what we're looking for is something like this. So when we see no ST depression, the EKG looks the same at the beginning as it does at the end of exercise, we're very happy about that. If we see that there's upsloping ST depression, so you see how this sort of goes up at the end, it's not really flat, it's sort of flat, but it really goes up ever so slightly. That pitch goes up as opposed to this where the angle is straight across, and as opposed to this where it actually goes down. If it's horizontal or downsloping ST depression more than 1 millimeter, that's a positive stress test. Okay, independent of what the imaging says. But we always compare that with imaging, and one of the imaging that we can use is stress echo. So we can get echo pictures at the beginning, put the patient on the treadmill, exercise them, and then as soon as they stop, like we slam the treadmill stopped, and they jump off and go right onto the bed, and we immediately get pictures while their heart rate is still elevated, and then we compare the rest images with the exercise images, and we see if there's any blockage. Similarly, with nuclear imaging, it's a lot slower process. So we inject them in the morning to get the rest images. Then we exercise the patient, and when they exercise, we then inject them at peak exercise, let that circulate for a few minutes, and then we put them back under the camera again, and we get a second set of pictures. And then what we do is we compare the rest images with the stress images, and then we see if there's any difference between the two. So we're looking for this nice same coloration all through in the rest images and the stress images to make sure that they have no coronary disease. Now down here you can actually see in the inferior wall that during exercise there's less perfusion here than there is during rest. So this is a positive stress test actually here in the inferior wall. You can also see it up here in the inferior wall during exercise, and it redistributes at rest. Pharmacologic nuclear stress testing incorporates something called Bayes' theorem. And again, this is a little more testing theory than we really want to get into, but essentially this is Bayes' theorem is conditional probability. So if we know certain things about the patient, like they exercised for 9 minutes, like their blood pressure was controlled, like they had no chest pain, those kind of things then change our assumptions about the likelihood of disease, right? So every time we add to that information, that changes the probability that the patient will have disease based on the results of their test. And if we put all that stuff together, that's what Bayes' theorem is all about. Again, way too much information, but I was embarrassed when I first started my graduate program, when I went to hang out with nuclear medicine, and the nuclear medicine physician was trying to make me feel like an idiot, and he did a good job. He said, "I can't believe you guys don't even know about Bayes' theorem." Like, maybe I should. So I made it my job to learn about it. So after we do a stress test, then we often find out that the patient has a positive stress test, and then we need to do a cardiac catheterization. So there's lots and lots and lots of detail about cardiac cath, and I can't begin to tell you all of it, but let's just divide it into the simple stuff. And let's say that there's right heart cath and left heart cath. So with a right heart cath, essentially what we're doing is putting a catheter into the vena cava, the right atrium, right ventricle, floating it into the pulmonary artery. And when we do that, we get different waveforms and different pressure readings for each step along the way. So the right atrium gives you the right atrial pressure waveform. Then we get the catheter into the right ventricle. The waveform changes again based on the fact that the pressure is, very low at the end of diastole, but very high during ventricular systole. And then the catheter floats into the pulmonary artery where the pressure is higher in diastole, right? Because that valve closes, and we can see those pressures. And then we put it all the way out into the into the wedge position. And when it's there, that balloon occludes any flow. And now all we're doing is seeing what's distal to that balloon, which is essentially the left atrium, and that's a left atrial waveform there. All right, we'll talk more about that when we talk about Swan-Ganz catheters later in the semester, but know that this is what we do during a right heart cath. We get the CVP, we get all the pressures on the right side, and we can also draw blood from each of those places. The superior vena cava, the inferior vena cava, the right atrium, the right ventricle, the pulmonary artery, the distal pulmonary artery, and then we can see if there's a hole in the heart anywhere. If there's an ASD, or an atrial septal defect, then the saturation should be much higher on the right side than normal, right? So those things can be done. We can also calculate the cardiac output. We could, if we need to, do an endocardial biopsy, and if we really need to, we could do a transeptal approach to get to the left atrium to measure those pressures directly. So those are most of the things that we can do in a right heart cath. Then the left heart cath, which is what you're probably accustomed to, is where you go through the artery. Of course, the right heart cath, we go through the femoral vein usually, but for left heart cath, we go through the radial artery or the the radial artery or the femoral artery, and put the catheter into the left heart. And here we can do pressures and waveforms again. We can do put the catheter into the left ventricle and then pull it back into the left atrium or into the aorta and see what the pressure difference is there, see if there's aortic stenosis, for instance. We can inject into the coronary arteries to look at the coronary arteries. We can do a ventriculogram where we inject dye into the ventricle and watch it pump. Those are some of the things we can do in a left heart catheterization. So this is that pullback that I was talking about, where we have the catheter in the left ventricle, and here we see the pressure is 107/13, right? So this is the left ventricular systolic pressure, 107, and in diastole it's 13, and then they pull the catheter back into the aorta, and now the pressure is 86/60. Well, that's a big gradient between the aortic systolic pressure and the LV systolic pressure, right? So there's a lot more pressure being generated in the ventricle than is being generated in the aorta. And the only way that happens is with aortic stenosis or some other obstructive cause. So coronary angiography, again, goes through the right femoral artery or the right radial artery, and then we put the catheter into the coronary arteries, inject the dye, and we can see things like this. So this is a right coronary artery. This is actually transradial catheter that's going in to the right coronary artery. Dye is injected here, and we can see the right coronary artery. You can see this, I would say it's probably about an 80% blocked proximal RCA, and then there's some disease down through here. See how it's real big here and real thin here? So this is, 50-60%. And then there's vessels further down, the posterior descending artery, the RV branch, the posterolateral branch. Those are all the branches of the right coronary artery. On the left, we see the left main coronary artery here, which then gives rise to the circumflex that goes around the back of the heart, and that produces the obtuse marginals that go down the obtuse margin of the heart. And then the LAD comes off of the left main and goes and gives off these septal perforators that go into the interventricular septum. And the rest of this goes down all the way to the apex of the heart. And the other vessels that are given off here to the other side are the diagonals. So those are the vessels that we see in coronary angiography. So that's all the cardiac stuff. So let's talk about some of the other tests and labs that we do in critical care. Remember that hydrogen is very precisely regulated in the body, and the way that our bodies do it is with these three related and interconnected systems. The buffer system, which is immediate, and there are buffers that float around in the blood, and as soon as acid is introduced, these buffers interact with it and neutralize the acid, so that we maintain a very specific pH between 738 and 742. If we get a little acidotic, then we get to 735 up to 745, and that's what we consider our physiologically normal zone. But usually we're between 738, 742, and by the way, 7.40 is perfect, right? So that's what we're always trying to achieve, is perfection. Notice that if we get lower than a pH of 6.8, we're dead. And if we get higher than a pH of 7.8, we're dead. And the things that keep us in that normal range are the buffer system, the respiratory system, which, by the way, is about twice as powerful as the buffer system, but it takes minutes to hours for it to work. And then finally, the most powerful is the renal system, by far, with bicarbonate and all that other stuff. But it takes hours and frequently days for that to really work. So all these three things work together. The buffer system is immediate, but not terribly strong. Respiratory system, by blowing off CO2, we can get a little better. And the best buffering that we get is through the renal system, but it takes a long time. So this nomogram here we can use to figure out if somebody's in metabolic or respiratory, primary respiratory or metabolic problem. And it also helps us to determine if they're alkalotic or acidotic, right? So based on all the components, the bicarb, the pH of the blood, and then the PCO2, which is reflected on the lines here, we can figure out what's what. So if I look right here in this normal range, I can see that a normal bicarb of 24 with a pH of 7.40 and a PCO2 of 40 is normal, right? That's exactly where that point in the middle ends. And so any of those other permutations can be plotted here to determine whether we have metabolic or respiratory condition and whether it's acidotic or alkalotic. But we also learn tricks to figure this out, and we will talk about these later in the semester. But know that when we get a blood gas, we can determine the pH. So if it's, then we can use this algorithm to figure out what our real issue is here. We're going to talk about this in more detail later, so I won't bore you with it right now, except to say that when we have the marching metabolics, right? Notice that the pH goes in the same direction as the bicarb, goes in the same direction as the PCO2. Those are the marching metabolics. So we have a metabolic process when all three of those things go in the same direction. Whether it's acidosis or alkalosis, they all go in the same direction. As opposed to respiratory problems where the pH goes in the opposite direction of the CO2 and bicarb. All right, so that's a little hint for you to use. I like remembering about the marching metabolics where all three of those things are in perfect line. Some other pulmonary diagnostic tests. Well, a lot of what we deal with in pulmonary is these microorganisms, right? So we have the benefit of being able to get a gram stain and CNS that helps us to identify what kind of organisms these are, if they're gram positive or gram negative. Well, what does that tell us? Well, remember, a gram positive organism is relatively simple when you compare it to a gram negative organism. Look at all this other stuff that exists here. This is a lot messier. It's a lot harder to kill these organisms than it is to kill a gram positive organism. So that's why it's important that we at least get an idea from the outset what kind of organism this is. So to do that, we can get somebody to give us a sputum specimen. While we're on it, though, I want to talk about something else, another way that we classify organisms as either aerobic or anaerobic infections. So remember that aerobic requires oxygen, and so those things tend to grow where the body has a good blood supply. But anaerobic infections typically occur where there's some flora, and usually it's just the patient's normal flora, but it gets walled off from a blood supply, so there's no way to get blood to it, there's no oxygen there, and these anaerobic organisms grow. And this is what typically happens in abscesses. So remember that anaerobic infections are typically where there's a walled off growth of organisms, and it's walled off from a blood supply. We see this in abscesses quite frequently. All right, back to the sputum gram stain. So we can get our patient to give us a specimen, and they cough something up and expectorate that into a specimen container, and then we send it to the lab, and somebody in the lab has the unpleasant job of doing a gram stain on this. So how do we tell if the specimen is any good? Well, what is it that lives in the lungs? Remember that there are these polymorphonucleocytes, or polymorphonuclear leukocytes is the other way to say it. So these PMNs live in the wall or in the lining of the trachea and in the bronchi. And if we see a whole bunch of those PMNs, then that tells us that that specimen is probably a good specimen that comes from the lungs, as opposed to getting a lot of epithelial cells. Remember when you were in 9th grade in biology class, and the first thing that you looked at under a microscope was the cells from inside your cheek? Well, those were epithelial cells, right? So if we look under the microscope at this sputum gram stain and we see a whole bunch of epithelial cells instead of a bunch of PMNs, then we know that we're looking at spit under the microscope instead of sputum. So that's a really important thing, right? And it makes sense. It's pretty simple to understand once you hear it explained. But then we can believe what we see in the way of organisms. Gram-positive cocci, gram-negative cocci, bacilli, whatever. So the first step is to look and see there's moderate WBCs or PMNs and few epithelial cells. That tells us that this is a good specimen. Now I can pay attention to what it says here. Many gram-positive cocci and a few yeast. All right, so I know that it came from somewhere deep in the lung because there's a lot of white cells and few epithelial cells. It's a good specimen. I can believe what I see here. Next thing we do then is we send that to the lab. Well, it's already in the lab, right? And then they can put it into an incubator and see if it grows. And so after a day, they pull it out and they look under a microscope and they see if there are any organisms. And on this day, on November 2nd, 2013, preliminary reading was that there was no growth. But organisms don't grow overnight all the time. And so the next day when they read it, on the 3rd, they saw gram-negative rods. Well, it was too early in the process to be able to identify what those gram-negative rods were. So on day 3, they saw now there's gram-positive cocci in addition to the gram-negative rods, and it says ID and micro will follow. And then they did all the tests for it like you did in microbiology lab, and you see that organism 1 was Proteus, and organism 2 was MRSA. Methicillin resistant Staph aureus. Now, how do they know it's methicillin resistant? All right, here's a little secret for you. Nobody tells you this, but notice that when we look at the sensitivities down here, there's no such thing here as methicillin. Do you see methicillin anywhere? No, I don't see methicillin. Well, that's because they don't make methicillin anymore, but we still call it MRSA. We still call it methicillin resistant. So the trick that you have to know is that methicillin, we use oxacillin instead. All right, so methicillin resistant Staph aureus is actually oxacillin resistant, and you can see here that it was resistant, right? So the way that we read this is any of these things that have an S beside it are actually sensitive. Now, we don't worry so much about the number that's associated with it, just whether there's an R or an S, because these numbers aren't comparable between among themselves. So just look for any of them that are sensitive and you're good to go. All right. Pulmonary function tests and spirometry. Refresh your memory here on what the components of a breath are. So you know this inspiratory reserve volume is a function of the vital capacity less the tidal volume and the expiratory reserve volume. And you can, there's like a million different combinations of all these things, right? But when you add them all up, that's total lung capacity. And in most people, that's about 6 liters when you take into account the residual volume, which you can't get rid of, and the expiratory reserve volume, which is the part that's still in your lungs after you blow out a normal breath, and then the tidal volume and the inspiratory reserve volume. Now, we also can do the spirometry then, and we can see with these pulmonary function tests what the shapes are. So in a normal patient, the inspiratory and expiratory flows look like this. But in emphysema, it gives you this shape, right? And in mainstem bronchial obstruction, it gives you this, etc. So these are just for you to look at and sort of play with. The important thing is that when we get PFTs, we determine how good somebody's breathing is and what is behind their breathing problem, such as emphysema, like this shape. Chest x-rays, we do a ton of chest x-rays. And why do we do them? Well, because they're simple, right? It's easy to do that, and they're safe. They really don't require very much radiation exposure these days anymore at all. And we can see a ton of stuff. We can see tubes and lines and wires and previous surgery, and we can see infections like pneumonia. We can see air in the chest like pneumothorax. We can see fluid in the lungs like pleural effusions and tumors and all sorts of stuff. Like, this test is really good. And it's one of those things that you can get good at doing as a nurse as well, because we do so many of them. So some of the things I want to point out to you are, we're looking at the quality of the film. So if you look here, you can actually make out the vertebrae here, and that tells you that that's a good quality film. The penetration is good because I can see the individual vertebrae back here. Now I'm also going to look here and see, notice there's darker color here. This darker color I can trace down here, and I can trace down here, and those are the bronchi here. This, where they come together, is called the carina, and if we had an endotracheal tube in, we would want it about 2 centimeters above the carina. This is the carina here, so we'd want that tube to end about here. If they have lines in, we'll see the lines go in here and down into the heart. The heart's down here. I can see how big it is. I'm looking over here at the costophrenic angles. These angles here tell me if there's fluid. So right now I can see those costophrenic angles, so that's good. But if there's fluid there, this is all going to be white. It's going to look just like this all the way across, and maybe even up a little bit. So so this is a totally normal chest X-ray. It looks beautiful, and I'm very happy about this. The other thing you should know is that there are differences between AP and PA films. So an AP film is shot anterior to posterior, and this is what we get in the ICU. The X-ray people come, and we put a plate behind the patient's chest, sit them up straight, put a plate behind their chest, and then we shoot from the chest or from the front of the chest to the plate behind them. And that gives us a bit of a different look compared to a PA film. This PA film, you can see we don't really make out the vertebrae as well, because that's further away, right? It casts a shadow, as opposed to the AP film, where we can see that because that's right against the plate. The spine is right against the plate here, and so there's no magnification from that. The other way that we can tell is that you can see the breast tissue here, or the breast silhouette, and that's because the patient is hugging the machine, and the plate is on the front, and then we shoot through the back. So this is done in the department usually. We don't do it in the ICU because there's no real way to do that. But we always prefer PA films over the AP films, but what we usually get is the AP films. There's computed tomography, or CT scan, and this was published in the New England Journal recently, and I just love this. This is a CT scan that was done somewhere in the developing world. I think it was in India maybe, and just take a look at it for a second and figure out what it shows. What it shows is this tumor down here. This is a lung tumor that's caused by this. This is a pack of cigarettes that the patient had in their shirt, and here's the lighter that they had in their shirt when they had the CAT scan done. It's fascinating, isn't it? But CT scanning is actually an X-ray technique, and we then can slice the body up, or the part that we do, we can slice up and see all sorts of stuff, like all the lung tissue here, and the heart here, and the vertebrae here, and the aorta, etc. So all sorts of stuff that we can see from here. A CT angiogram is where we do that same CAT scan, but in addition, we give them some IV contrast, and then that helps us to look at things like the aorta. So here is a type A aortic dissection, and here you can see the false lumen over here and the true lumen here. Maybe it's reversed, I don't actually know, but there's definitely a false lumen and a true lumen that you can see divided here. So this does require IV contrast, which, by the way, can be a kidney problem, right? Or can pose kidney problems, can cause acute tubular necrosis. So we have to be very diligent about protecting patients with kidney problems and decide if this test is really necessary or not. The other thing we use it a lot for is for pulmonary embolism. And here we can see these are the lung fields, again, these black things. And when we look here, we're looking for the IV contrast that shows up as white. And so you can see that the pulmonary arteries, which are in cross section here, we can see are filled with white. But on this side, you can see it's gray with a little bit of white around it. Well, this is clot, and that's why it's gray. It's higher density, but it's still letting some of the IV contrast get through. And so these are individual pulmonary emboli that are seen here. The other thing that actually the pulmonary angiogram, pulmonary CT angiogram replaced was the ventilation-perfusion scans. And these VQ scans, and by the way, there should be little dots above the V and Q. I don't know how to do that on my Mac, so whatever. This is what you get. But these VQ scans then were used and can still be used today if you don't want your patient to get a big dose of radiation from the CT scanner. You can get these VQ scans that are nuclear medicine scans that give a smaller dose of radiation, and they're the ventilation. There's inhaled radioactive isotope that shows the ventilation part, and there's injected radioactive isotope that shows the perfusion part, and then we compare those two. And I don't actually know how to read these, but that's why we have radiologists in the world. And then, of course, the gold standard for pulmonary embolism is pulmonary angiography, where you take a patient to the lab and you interventional radiology, they put a catheter into the pulmonary artery and they shoot the dye into there, and then they look and see if there are any blockages. And apparently one showed up here as a pulmonary embolism. Bronchoscopy is something we do a lot in the intensive care unit. It can be either diagnostic or therapeutic. So bronchoscopy is a very cool thing because it's done in real time. And in this particular case here, we see at this bifurcation of the trachea or the bronchiole, the bronchus, I should say, we can see that there's a soft tissue tumor here that's occluding the bronchus. Lastly, then, the other thing that we can do is a thoracentesis. Oh, and by the way, this bronchoscopy can be either diagnostic or therapeutic, right? So we can go in there and look, and sometimes if we see something like a mucus plug, we can actually pull it out and restore lung function. Similarly, a thoracentesis can be diagnostic, so we can get some fluid out, put it under a microscope, send it to the lab, see what it's made of, and that will tell us if it's exudate or transudate. We're hoping for transudate, right? But it could be exudate too, which is essentially pus in the chest. Some abdominal tests that we do, by far the biggest and easiest one to do in the intensive care unit is the abdominal flat plate, but it's followed closely by ultrasound. So the ultrasound we can get the lung in there, we can get the abdomen, we can do the liver and gallbladder, we can see blood in there, we can, in the belly, we can do the retroperitoneal space, we can look at kidneys, we can do all sorts of ultrasounds. In this case, there's some sludge that's showing up in the gallbladder here, and that's a very diagnostic study. So this can be done at the bedside. This is a big growing field where intensivists have a little machine that they push around in the ICU, and they can image things on the spot. It's pretty cool. We also do a lot of endoscopies. So we can do upper endoscopy. That's the way I prefer to refer to it, rather than EGD, which stands for esophagogastroduodenoscopy. We just call it an upper endo. And the way that works is the endoscope gets inserted down here. Notice that at the bottom or at the end of the endoscope, there are these components. There's a lens, there's a light that shines, there's irrigation where there's just, you squirt water into it. And then there's an instrument port where you can put things in like a tube to get a specimen or, a biopsy or what have you. So this is a very cool thing. And then we can also do a colonoscopy. Now, an EGD can be done at the bedside, in urgent conditions, and we do that for bleeding a lot. But the other thing, this colonoscopy idea, this requires a prep, right? You have to clean out the colon, and that takes at least 24 hours to prep somebody for a colonoscopy. A HIDA scan is something that is commonly done in the hospital for people where we're concerned that they have some sort of biliary tree problem. So whether they may have gallstones or gallstone pancreatitis or whatever, a HIDA scan can help us figure that out. Lastly, we're going to talk about neuro imaging and know that we have two different ways that we can image the brain primarily, and those are MRI and CT. So we've talked a little bit about CT before. Notice that the MRI image on the left here gives us a much better detail, although these pictures aren't terribly clear. This gives us much better detail of the soft tissue here. So I can see the brain tissue in much better detail in an MRI, which tends to be better for soft tissue, than I can on the CT scan, which is better for bone. And by the way, you can see, look how bright this skull is here. Well, that's because this is a CT scan. And the CT is good at looking at bone. Over here, it's not very good at picking up the bone, right? It doesn't really allow the bone to be well visualized. So that's one little hint that you can use to determine if you're looking at an MRI or a CT scan. We do use CT scans for acute stroke because it's easy, it's convenient, it can be done relatively quickly, and if we're going to see bleeding, and that's the reason that we do it, right? We determine clinically that the patient's having a stroke, and then we send them for a CT scan to see if it's a hemorrhagic stroke, because that changes how we manage it. The MRI machines are gazillions of dollars. And essentially what they do is they use these super strong magnets to align the atoms, literally align the atoms in our brains or wherever we're imaging. And when we do that, then it sets up different contrasts from one type of tissue to another type, right? The cool thing about MRI is that there's no radiation. The downside, if you've ever had one, they're loud, they take a long time, they're very isolating. So, and of course, there's a magnet there, a very powerful magnet that has to be used. So they're not for everybody. It can be a big pain to get one done, and they're very expensive. Just like CT scans can be done with or without contrast, so too can MRIs. Well, because metal is very magnetic, we can inject liquid metal. And if you can think of any kinds of liquid metal out there, well, let's see, mercury. Probably not something that we want to use, right? Don't you get mercury poisoning when you're exposed to it? I think so. So gadolinium actually is from this weird part of the periodic table. Remember this? What are these? The transition elements, I think. But I remember that they don't really meet all the same criteria for the other things. But the one thing about gadolinium is that it can be somehow put into a solution that can be injected into the human body, and it's highly magnetic, and so it will show up where blood is. And so gadolinium is kind of cool in that respect. There are some problems with it. It can get stuck in the brain. I understand there's some concern about chronic gadolinium uptake in the brain after repeated studies. I'm not sure how real that is or how important that is clinically, but there may be some limitations with gadolinium. The cool thing is that it's not nephrotoxic, so you don't have to worry about giving gadolinium and poisoning somebody's kidneys acutely. So when we use this gadolinium stuff, we can get magnetic resonance angiography, or MRA. And so here we can see in this particular study the vasculature in the brain, and smart people can actually look at this and tell what vessels they are. But these MRIs, this is a road trip. If you're an ICU nurse, you'll have to take a road trip to the MRI machine. At Hershey, we actually have a CT scanner that is portable, and it can come to the ICU. They have to close down that hallway. Nobody can go past it, because it releases a ton of radiation. But the MRI machine is not like that. You actually have to go to the MRI machine. And then finally, with respect to the imaging, carotid and cerebral angiograms can be done. And again, this is where we put a catheter into the aorta in this case. And at the aortic arch here, we can inject the dye. This, by the way, this white thing here is the catheter. And so we can inject the dye that goes up the carotids, and then it can go up to the brain. And I gave you this little picture that shows you all these vessels. This is very complex stuff, and it's hard for me to remember which all these vessels are, but I suppose if I worked with it every day, it would become much easier. So this is again the gold standard for looking at the arteries in the head, neck, and brain. Another test that we use a ton in neuro is the EEG. And the EEG is really just brain waves. It's looking at brain waves to see what's going on. If the patient is awake, if they're sleeping, if they are in a coma, or if they're brain dead. Those are all things that we can determine from the EEG with varying degrees of accuracy. So we don't use EEG by itself to determine brain death. Rather, that has to be combined with some other tests, like, for instance, a nuclear study of the brain. Now, this is a really creepy image, and it's creepy enough when you know that this is a person's head that is being imaged. But when you realize what's going on here, it's even creepier. So what's going on here is that the patient sustains such a head injury that the pressure inside the brain from the massive amount of edema is so great that it prevents any blood from flowing into the brain. So up here is the cranial vault, right inside the cranium where the brain is, that is getting no blood. So this is called a no-flow study, and this no-flow study determined that this patient was brain dead. The interesting thing is that you can see, although it doesn't go up the internal carotids to the brain, the external carotids still have flow that goes to the face, and in this case produces this this sign, because this is a three-dimensional structure, right? So more of the radioactive isotope gets collected in the nose here, and this is called a hot nose sign. So it's kind of a creepy image, but this is one of the tests that we can use for brain death. So that's all I have for you this week. I want you to watch the video. Obviously, if you're listening to this, you have watched the video, right? And then make sure that you read the book. There's activities online for you in this module for this week, and I look forward to talking to you next week.